Good morning, everybody. Thank you for your attention. I am a dermatologist and I have a focus clinically on melanoma. So I'm taking care of patients with melanoma and also people who are at high risk for melanoma. So we'll talk about that today. So in order to sort of, do my job as a dermatologist, it's really important to understand where melanoma comes from, who gets melanoma, what are the subtypes of melanoma that occur, how do we diagnose melanoma, and how do we follow our patients with melanoma from the dermatology angle. So first and foremost, what is melanoma? Melanoma is a tumor of melanocytes. It is a malignant tumor of melanocytes. And melanocytes are the cells. Is there a pointer on here? Okay, so melanocytes are seen on the left on the normal skin panel. They are the brown round cells. They are located just above the basement membrane of the skin. This is a cross section of the skin where you can see the top layer epidermis, the basement membrane, and the dermis and the fat underneath. And they sit pretty much individually and they have connections to the nearby skin cells that are called keratinocytes. And they actually kind of reach up and above the keratinocytes and protect them, little umbrellas over their nuclei to protect from UV damage. Now, if they group together in a ball, but they are behaving normally, that is a mole. Okay, so that's benign. But if they group together like the middle panel and they're larger with atypical nuclei, and that is melanoma. So that's a malignant grouping of melanocytes. If they stay above the basement membrane, that's what we call melanoma in situ. If they start invading below the basement membrane, that's what we call invasive melanoma. So this is just giving us some framework. So why do we care about melanoma? All of us here care about melanoma a lot, but why do we care? We care because it is the most common potentially lethal form of skin cancer that there is. And it is one of the leading cancers that results in average years of life lost because it can affect young people. So in 2017, it was the 13th out of 45 cancers responsible for years of life lost. And as Dr. Lipson mentioned, when we have sort of distant disease, if you can see stage 4, that those numbers have increased. This is based on 2014 to 2020 data, but the stage 4 disease has a 35% 5-year relative survival rate. But if you look at local stages 1 and 2 that are highlighted in yellow, we see a 99% survival rate, okay? So our goal as dermatologists is to not actually have our patients have to see the medical oncologist. No offense to our medical oncology colleagues, but we want to get patients who have early stage disease that can be cured with surgery. So as dermatologists, we need to find who is at increased risk. Who are these patients who are at increased risk so that we can diagnose melanoma when it is early and very easily curable. So to do that, to find out who is at risk for melanoma, we have to go to epidemiology and say, okay, let's look at the incidence of melanoma. Who's getting melanoma? When are they getting it? And then we can look at risk factors. So if we start looking at sort of incidence of melanoma in the US, a lot of our data come from large database studies, including the National Cancer Institute's Surveillance Epidemiology and End Results Study, which is called SEER, and also the American Cancer Society. So we look and we see that melanoma has actually been increasing in incidence over the last many years. It was sort of stabilizing, but it looks like it's actually still continuing to rise. So in 2025, melanoma is the 5th most common cancer in men and women. There's about 105,000 estimated new cases of melanoma in the US for this year, more in men than women, with about 8,400 estimated deaths, more in men than women as well. And interestingly, the incidence of melanoma varies based on age and sex. And this curve has played out for the last several years. You can see on the left column is the incidence rate per 100,000, and the x-axis is the age at diagnosis. These are 2 different time groups, so 2003 to 2005 and 2013 to 2015. And this is among Hispanic and non-Hispanic whites in this year database. And what we see is something interesting happening between ages 40 and 50, where before age 45, melanoma is more common in young women. And then after age 45, it's more common in older men. Okay, so this gives us a sense of sort of who's getting melanoma and when are they getting it. Other age differences that we see when we look at melanoma epidemiology is that when it comes to who has sentinel lymph nodes that are positive, more young people than old people tend to have positive sentinel lymph nodes. When it comes to survival, more young people have better survival than older people. For sex differences, we can see that in terms of the location on which melanoma arises. So men tend to have melanoma more commonly on the trunk or the head and neck, and women, the most common location is the leg. We also see more adverse features of melanoma in men compared to women. So more of the melanomas are ulcerated in men, and the thickness tends to be greater in men. We also know that the incidence of melanoma varies greatly by race and ethnicity, and this is another from data from the SEER program, looking at incidence rate again on the y-axis. This is now looking at year of diagnosis, and the yellow is Caucasians. The black line is all races combined, but if you look at the green and purple line, that's Asian Pacific Islanders and Alaska Natives, and then the red and the blue on the bottom are Blacks and Hispanic patients. And you can see that Caucasians have much higher incidence rate than other races. And this has been from 1999 till 2014. It's still the case. So this also helps us to understand who's getting melanoma. And we know that, we see that the melanoma incidence, it's not just, one factor at a time, but that really all these factors sort of interact with each other. So for example, being older and male can lead to worse outcomes. So there's interactions between these factors. We can also use epidemiology to help us identify what the risk factors are for melanoma. So we can tease apart melanoma risk factors, and it can help us identify who needs to see us. And we know that these factors, so there's genetic and environmental risk factors, they work individually as well as in combination to contribute to melanoma development. So if we look at family history on the top in yellow, we know that people who have a first-degree family member with melanoma themselves will have an increased risk for melanoma. If we look to the left side in green, pigmentation traits, we know that patients who have fair skin, light colored hair, red hair, easy freckling, poor tanning ability, sun sensitivity, those patients have an increased risk for melanoma. If you look to the right, people who have just an increased number of benign appearing moles have an increased risk for melanoma, and those who have what we call dysplastic or atypical moles also have an increased risk for melanoma. On the bottom in red, we see the only known environmental risk factor that we currently know of for melanoma, which is exposure to ultraviolet radiation. That can be in the form of sun exposure or artificial tanning. So if you're wondering, well, how much do each of these factors contribute to melanoma development? These are some numbers as to how each of these can increase risk. And I just want to point out, if you look at the mole or nevi category, how strong that risk factor increase is. So for people who have more than 5 atypical moles or dysplastic moles, they have a 10-fold increased risk for melanoma. That's pretty high. And same for people who have a lot of moles. So having over 100 moles, there's a 6-fold increased risk for melanoma. And that's a lot higher than the other categories, if you notice that. And one other comment is that these factors sort of interact together. So people in the same family tend to also have similar pigmentation traits and travel together. So they might have the same sun exposure when they all go to their sunny locations in the summer. So these are also kind of interacting together. One other risk factor for melanoma is immunosuppression. So these are patients who most commonly are solid organ transplant recipients and are receiving immunosuppression for their organ transplant, or patients with chronic lymphocytic leukemia. They also can have an increased risk for melanoma. So we don't want to forget about that as well. I'll talk briefly about family history. I think a colleague is talking more about genetics later. But in terms of sort of patients wondering if they have a genetic susceptibility to melanoma in families. Back up. Only about 10% of melanoma that occurs is within sort of a familial setting. So most people with melanoma, it is considered sporadic, but we are learning a lot more about melanoma susceptibility genes. The most common, frequently identified one being CDKN2A, but hopefully we'll hear a little bit more about these later. Okay, so when we're trying to diagnose melanoma, it's important to know what subtypes of melanoma exist and what they can look like. So we're going to start with the most common subtype, which is superficial spreading. This is, we'll talk later about the ABCDEs of melanoma, but if you guys know about those, that the superficial spreading subtype sort of fits that bill. And again, we'll come back to that. So this is the most common subtype. Nodular is the second most common subtype. These are often very fast growing. They are often bleeding, as you can see with this, and sometimes the surface may be eroded or moist. That's pretty common. These can be very, very fast growing. Lentigo maligna or lentigo maligna melanoma occurs most frequently in older individuals on chronic sun-exposed areas, so the face or the back of the hands, or in this gentleman on the left, his upper back, which has a lot of sun damage in the background. Acral lentiginous melanoma can occur on the palms of the hands or the soles of the feet or in the nail units. You can have mucosal melanoma. Now this is, much rarer than the other types, but in the oral cavity, anorectal area, or vulvar area. Desmoplastic melanoma is a subtype that often can look like a scar. These can be pretty deep. And then there's amelanotic melanoma, and I like to use this to quiz my residents as to which one they thought was the concerning lesion, and it's actually the red one, not the dark brown one. That was an amelanotic melanoma. So these are pink or red melanomas. Okay, so how we make our diagnosis, this ties into how we're going to recognize melanoma early, is we use clinical exam, of course, but we also use dermatoscopy or dermoscopy, total body photographs, and biopsy. So everybody's probably heard of the ABCDEs, but to go over these, this is a helpful tool to teach patients. And, it's probably something we do automatically as dermatologists, but the column on the left shows sort of benign features of benign moles, whereas on the right, these are features of melanoma. So we talk about so a normal mole should be symmetric, one half matches the other half. If you have an asymmetric pigmented lesion, that could represent melanoma. B is for border. We expect borders to be even, to be able to tell where the mole ends and the normal skin begins. In melanoma, you might have jagged or irregular borders. C, color. There's two aspects of color that I teach patients about. The first is most moles will normally be one shade of a color. Melanoma might have multiple shades. So if you see a multicolored pigmented lesion, red, pink, light brown, dark brown, that can raise your suspicion. The second aspect of color is that if somebody has mostly medium brown moles and then there's a very, very dark black mole or pigmented lesion, that stands out as being sort of different from their other ones, and that may be an indicator of melanoma. D stands for diameter. That's the kind of the least important. We know there are normal moles that can be bigger than that, and melanoma can be smaller than sort of the size of a pencil eraser, which is what we teach people. But so that's not the most important criteria. E, however, then next is the most important criteria. So this is evolution. So this is something that is new or changing. And so if we can, really try and figure out what's new or changing of patients' pigmented lesions, we will be ahead of the game in terms of finding melanoma early. And this is another thing we utilize, a tool we utilize and teach patients about, which is basically looking for the ugly duckling. So if there is something that stands out as looking different than their moles, especially for patients who have a lot of moles, and they may have a lot of atypical moles, and we can't take everything off because we're going to leave them with, tons of scars. So we say, okay, well, this one really stands out and looks different from your others. So that's kind of the ugly duckling sign. Back to, okay, so another tool we use, is dermoscopy. And this is a handheld, non-invasive tool. It's a magnifying lens with a polarized light, and we look at individual pigmented lesions with it. And it can help us see pigment networks and structures such as blood vessels that otherwise are not visible to the naked eye. And in studies, this has been shown to increase the diagnostic accuracy for melanoma compared to visual exam alone. So what we are looking at, these are some images. On the left is sort of just a schematic for how we teach our dermatology residents what to be looking for in terms of normal patterns. The middle column are actually benign lesions that fit those schematic patterns. And on the right column going down are melanomas that have some elements of those normal patterns, but then do not have the full pattern. So this includes sort of a reticular pattern at the top, which is a lace-like. If you look at the one in the middle, that's globular. These are sort of how we describe what we see when we look with a dermatoscope. And we can use this tool to find patterns that we wouldn't otherwise see if we're just looking with our eyes. So dermoscopy is a very important tool. And there's pretty good evidence that people who are doing skin exams should be trained in dermoscopy. So if you're going and you're getting your skin check, you really want a dermatologist who's using a dermatoscope. Now back to the E for evolving. So how can we know if a mole is changing unless we have some type of baseline record of what it looks like? So we use total body photography. There's many different systems to do that, but that basically record sort of a baseline image of patients' pigmented lesions, either all of them or select ones that the dermatologist wants to keep an eye on. We can do clinical photographs, just a regular picture of a mole. We can also photograph the dermoscopic image and follow that over time. But basically, we know that most moles that are benign will be stable throughout people's lives, okay, especially beyond childhood. And so using total body photography, we can monitor changes in pigmented lesions over time, and therefore find melanoma at a really early stage before it even has any obvious features clinically, or even sometimes dermatoscopically as melanoma. But we say, this has changed, let's take it off. There are different approaches for obtaining total body photographs with a range of costs. And as our iPhones and smartphones are getting better, I often will use the patient's phone and take pictures and hide them in their hidden folder, so they can access them, but they're not sort of, going to show their friends when they are showing vacation pictures. It does add time to the skin exam. So, that's a downside of kind of dermatologists adopting this, but it really can improve the early detection of melanoma. And especially this is for patients who are at high risk for melanoma. And furthermore, it reduces the removal of otherwise benign lesions. And so we don't, patients will come in and say, can you just take all my moles off? I'm really anxious about them all. And we say, no, we don't want to, leave you all scarred up, but we need a tool to be able to find the needle in the haystack, to find the one that's changing. So if we look at an example of using total body photography, we see a picture from August 2023 that already has an arrow on it. So we're already monitoring it, whether it was starting to change a little bit at that time, and then definitely changed by September 2025, and it was a very, very early evolving melanoma in situ. So fortunately, fully curable with surgery. In terms of actually diagnosing melanoma, so those are tools to identify melanoma, but really the biopsy is the gold standard. We need to do a biopsy. There's no substitute for removing the lesion and having it evaluated by pathology. And Dr. Lang will talk later about what goes into that pathology report. There are some modalities that are being evaluated and studied that may help us to identify melanoma in the future, some of which may be non-invasive. So tape stripping, you can take a little bit of the mole with a special tape that can look at gene expression patterns. That may be something that we use regularly in clinic in the future for sort of ambiguous, suspicious pigmented lesions. Confocal microscopy actually looks even deeper than dermoscopy at structures and may be helpful, although the Currently, the confocal microscopes are huge, so it's a little bit cumbersome for clinic. Optical coherence tomography and electrical impedance spectroscopy use sort of surface changes and light and spectral analysis to try and identify benign versus malignant lesions. And then what's really exciting is sort of what's coming with artificial intelligence modalities to use non-invasive techniques to recognize benign versus malignant lesions. And if we can get their accuracy as good as we are or better, I joke with my patients, I'll be very happy to just push the button on a computer one day and let the computer find their melanomas. They still will need somebody to push a button, right? Hopefully. So I won't be out of a job completely, but I welcome a computer doing it better than I can do it, if that's possible. So these are just some recent headlines on sort of these AI skin cancer detection systems. There was one actually approved by the FDA recently that was for primary care doctors. So that's another sort of piece of this is not everybody has access to a dermatologist. So if we can actually have a system where people who are in locations where they can't see a dermatologist easily could get a triage of sort of benign versus malignant of a lesion, that can help us sort of, give care to a broader patient population. So in follow-up, anybody who's had melanoma, we're going to be wondering if they have any new or changing lesions they've noticed. We're going to work up any systemic complaints they may have to just make sure that the melanoma they had hasn't spread anywhere. We do usually every 3 to 6 month full skin exams for patients in the first few years, followed by every 6 months till year 5, and then at least yearly. Sometimes patients who are covered with moles sort of stay at the every 6 month for the rest of their life. We use dermoscopy, total body photography for patients with an increased number of pigmented lesions, always do lymph node exam. And then we're looking at where the melanoma has been removed for evidence of recurrence. And sometimes the recurrence is obvious, like this gentleman on the left, he sort of barely has a resected melanoma from the top of his scalp, and just you can see the black all around and extending onto the scalp. That's not subtle. Whereas the patient on the right, it's a lot more subtle. So you can see the melanoma scar on the shoulder on the right side of the picture, and then 2 very small bluish brown papules that showed up, and that was melanoma recurrence as well. So part of our exam is also monitoring for melanoma recurrence, which tends to go to the skin. We do a lot of education of our patients. So we teach patients that they're at risk for a subsequent, which is sort of a second separate melanoma, as well as non-melanoma skin cancers, such as basal cell carcinoma and squamous cell carcinoma. We review the ABCDEs, what melanoma can look like, what non-melanoma skin cancers can look like. We teach patients how to do self-skin exams, how to use their total body photography. So if I take photographs, I actually want patients to have access to those photographs. I don't want to keep them locked in our clinic. And if they see a spot, I say, get out the pictures, see if it's changed, see if it's different. And if it's different, you should be sending us a message and we'll get you into clinic. We want our patients to encourage their first-degree relatives to get skin exams, encourage sun protective behaviors. And in individuals where there is a family history of melanoma, to consider genetic testing for melanoma susceptibility genes. And for our perspective in dermatology, when somebody's already had melanoma, we're going to be following them regardless. So I tell my patients, you having a melanoma susceptibility gene is not going to change what I do for you and how I care for you. But some of these genes increase the risk for other types of cancer. And that's where their clinical care may change. So they may open up the opportunity for them to have other cancer screenings that they wouldn't otherwise have if they do test positive for one of those genes. In terms of prevention, as of now, we don't really have great prevention other than sun protection, so protecting from the most common environmental risk factor. So not going tanning, using sun protective clothing, broad spectrum sunscreen, especially protecting the skin from the sun during peak sun hours. And I will say I have started really educating my patients about vitamin D as well. We are intentionally keeping patients out of the sun, which the sun is a natural form of our getting vitamin D for our bodies, which we know is important for bone health and possibly prevention of other cancers. And interestingly, there have been a lot of mixed studies on vitamin D, but there are some studies that do suggest that a low vitamin D may be associated with an increased melanoma risk or also increase worse prognosis in people who have melanoma. So I am telling my patients, look, I want you out of the sun, but get your vitamin D level checked. And if it's low, talk to your primary doctor about whether you need to supplement it. And then in terms of sort of the risk for another separate melanoma that does exist, that risk is highest in the first 5 years after their first melanoma is diagnosed. And that risk stays increased over 20 years from when their first melanoma was diagnosed. So I basically tell my patients, I'm your doctor for life. You're going to be coming to get skin checks forever because you can always have a second melanoma. And that's not the first melanoma spreading. That is a second separate melanoma. So think of questions, write them down, and I'm happy to answer them later. And thank you for your attention.